Okay, got a case I want to do. Here is the case. It's a 35-year-old. They present with difficulty speaking for 2 days, no sensory symptoms. You do work out that they have a history of IV drug use. What is the next step in management? So this is a classic sort of question where you have to work out what's going on, and then you have to work out the next step. And sometimes they're really difficult because the next step is never exactly as it is in the exams, because it all depends on where you work. But what could this be? What's your differential diagnosis here, and what might you do next? Think about it for a moment. So you've got a 32-year-old, no sensory symptoms, that's a big deal. And they've got difficulty swallowing, difficulty speaking perhaps, and they've got a history of IV drug use. The history of IV drug use is the key thing here. So let's talk about botulism. IV drug use, weakness of the bulbar muscles, botulism, botulism, botulism. So what is botulism? It is a toxin. It comes from Clostridium botulinum, of which there are like 8 different serotypes, and it stops release of ACTH from that presynaptic synapse. Whoa, come back here. Stops that ACH release, acetylcholine, and so you don't depolarize, so therefore your muscles don't work. And it classically occurs in the bulbar muscles first, in the face, difficulty swallowing, diplopia, difficulty speaking. And it occurs there probably because it's highly innervated, although there might be something else about it, it's not clear, but it usually affects the bulbar muscles first. Now there are 4 main types. There's actually 6, but we're going to talk about 4 main types. And that is, first of all, infantile botulism. That is the classic floppy baby syndrome. And what happens here is that the child is ingesting spores. So they're given classically honey. Because they don't have a very acid stomach, those spores can then germinate, produce the toxin, then they present as a floppy baby, and this usually occurs in the first few months of life, all right? Then there's foodborne, which is where you are canning stuff. You didn't prep it right. You got some Clostridium botulinum spores in there. They then replicate and produce the toxin, then you eat whatever's been canned, and then you get botulism. You come in really weak. So that's the classic one. And it's classically the can is a little popped open, like there's gas forming in there, Clostridium. Excuse me. Then there's wound botulism. Wound botulism can occur with any wound. Classically, though, it occurs with black tar heroin IV drug users. Black tar heroin IV drug users, you know, the needles have been on the ground, it's picked up the spores, you inject it, then it starts to replicate. That botulism comes into your serum up to your bulbar muscles. You present with weakness. But it can occur after a car accident or any significant wound. And then, of course, there is iatrogenic. You're getting it done to make yourself look younger, even though it doesn't. It makes you look like fish. And it gets absorbed systemically and they present with weakness. So they're the classic 4 types. These patients die by respiratory failure if untreated. The untreated mortality is close to 100%. It used to be 75% in the 50s. Now it's like 3% because we're really good at looking after the airway and we have the botulism antitoxin. All right, so that's the treatment. This prevents progression. It doesn't reverse it. It prevents progression. It doesn't reverse it. Time will allow those neurons to start working again, often weeks or months. But you can stop progression by using the botulism antitoxin. And you need to know there's 2 types. There is an equine-derived and there is a human-derived. The equine is cheaper, but it's associated with more anaphylaxis, anaphylactoid reactions. Human one, much less side effects, much more expensive, depending on where you are as to which one you have. But the key thing is to not wait for confirmation. The diagnosis of botulism is made on the clinical presentation and then isolating the toxin if you can. There's also a mouse thing that they can do where they inject the mouse with your serum and see if the mouse gets weak. But that takes a long time. So basically every textbook says the same thing. If you've got a really high suspicion that this person has botulism, get them the antitoxin, then go and try and get your samples and treat them as soon as you can to prevent progression of the disease. And then it is supportive care because they die by respiratory failure. So if we go back to the case, 32-year-old, difficulty speaking for 2 days. Obviously we'd want a lot more history than this, but there's no sensory symptoms. And they say history of IV drug use. If you've got bulbar weakness, IV drug use, botulism, done and done, treat them with the botulism antitoxin. So this would be the right answer. IVIG is for Guillain-Barré, which is part of the differential diagnosis, that Miller-Fisher variant, where it affects the bulbar muscles first. CT head might be the right thing if you're worried about stroke or other stuff, but you shouldn't have focality with botulism. And then intubation with rocuronium is probably right if they've gotten to that point where they just can't breathe and you need to intubate them. Don't use sucks, use rocuronium. And the easy way to think about that for exams is whenever there's a neurological condition, just use rock, forget about the sucks. And you can do this 20-second single breath test to determine whether they might need intubation. That's where you get them to take a breath all the way in, and then they count about 2 numbers every second for as long as they can. A normal person could get to about 50. If they're getting to less than 20, then this might be an indication that they need to be intubated. So it's 1, 2, 3, 4, 5, 6, all the way down as far as they can. If they can't get to 20, less than 20 is considered a bedside test where they might need to be intubated. Botulism, remember it. It's a foil. It's in lots of the neurological questions because it has a broad differential diagnosis, but it tends to occur in the bulbar muscles first. It's not associated with fever, and IV drug use is the classic one, and floppy babies is the other classic one. Herbert, out.